Welcome. We are thrilled to have so many of you joining us today. This is the virtual launch event of the newly released white paper, Generative AI for Health in Low and Middle Income Countries, the culmination of 5 months of research led by the Stanford Center for Digital Health. The link to download the paper will be in the chat. We appreciate those of you who participated in the research and everyone who has taken the time to read and share the report. We also want to thank the Advancing Health Online Initiative for their support of this work. My name is Abby Kosan, and I am the Deputy Director of the Bay Area Global Health Alliance. The Alliance supported Stanford's research through engaging our global multi-sector network and is now playing a role as the lead dissemination partner for this report. We want to acknowledge that this is a tumultuous time for the global health community. While many global health activities are at a crossroads, one area of continued growth is interest in GenAI and its potential to improve health and healthcare, both for behavior change and broader healthcare applications. Stanford CDH's research underscores many of the insights we heard through the Alliance's GenAI and Global Health discussion series in 2024, which will continue in 2025 with thanks to Pfizer. You can visit the link in the chat to learn more about that as well. Quickly, let me introduce the Bay Area Global Health Alliance. While we have Bay Area in our name, we are a global membership organization with more than 95 multi-sector members from across the world. Just over 1/3 of our members are based in the Bay Area, and 12% are based in LMICs. What makes us unique? We have strong ties to the tech sector, with 40% of our members having a tech focus. We serve as a neutral convener and catalyst for collaboration across tech and global health stakeholders. And we believe that collaboration across multiple sectors, expertise, and geographies is necessary to solve today's complex global health challenges and to advance global health innovation and impact. A few housekeeping items before we get started. This is a Zoom meeting, not a webinar. Please mute your microphones, but feel free to communicate and ask questions via the chat. Today, we'll hear from KX Jin, an advisor for Advancing Health Online Initiative, or AHO, who will provide background on AHO and the goals of the research. Dr. Eleni Linos, lead principal investigator and director of the Stanford Center for Digital Health, will provide an overview of the research focus. And then, together with 5 of the implementing partners featured in the case studies, we'll dig into each of the research findings. We will have 30 minutes at the end for Q&A and ask that you put your questions in the chat. Note that this is intended to be a learning session for all of us as we seek to surface opportunities for GenAI for health and understand what more is needed for these recommendations to be embraced. We hope to hear your feedback and encourage you all to actively participate in the discussion. And now I'm pleased to introduce KX, advisor for the Advancing Health Online Initiative.
Thanks, Abby, and thank you all for coming. I'm KX Jin. I'm an advisor to Advancing Health Online, which supported the work we're talking about today. I'd like to start just by giving a bit of context about AHO and the specific goals for this report before handing it over to Dr. Linos at Stanford Center for Digital Health, which led the research. So AHO is an initiative that focuses on advancing how social media and AI can improve the health of communities around the world. We created this in 2020. It was created by Meta and Merck, and it now operates as a fiscally sponsored project of global impact. The thesis behind AHO's creation is that efficiently harnessing the potential of technological change requires new ways of working across both the public and the private sector, but also across funders, implementers, and academia, really drawing on the complementary expertise and perspectives of each party. So with this in mind, AHO supports research and programs where the potential impact of this particular approach is high. As a few examples, over the last few years, we've partnered with Gavi, the World Bank, and others to support projects that give people access to health information and services over chat, as well as research to better understand consumer engagement, health impact, and the cost effectiveness of these types of approaches. So as you all know, GenAI has tremendous potential for impact in many fields, including in health. I worked at Meta from 2006 through 2023 during a period of pretty significant technological changes. And during my last 5 years there, I was its head of health. So my team worked very closely with many organizations around the world who were and still are focused on how to better harness technology for social impact. I no longer speak on behalf of Meta, but I personally believe that GenAI is one of the next major technological changes, on par with the rise of mobile phones and online communication over the last 10 to 15 years. It's my hope that we can learn from some of the lessons of how we approach the shift to mobile as we approach GenAI. As you also know, we've seen a lot of funding and investments go into the Gen AI space over the past several years. We thought it was important to take a step back and reflect on what we've learned. Why? Well, this will help inform future funding decisions and also help build capacity for the people doing the work. So with this in mind, Aho commissioned the research we're talking about to answer two key questions. The first is, where is Gen AI currently being used and what are some of the successes? And the second is, how can we work together to realize greater impact and unlock its full potential, both for behavior change and broader healthcare applications? It's important to note that Aho's goal here in supporting the work isn't just to produce this research in isolation, but to ensure that it has an impact on moving the field forward. So as we discuss things today, we'd love to hear from you about what parts of the research are immediately useful, as well as what is still missing, so we can keep working together. And lastly, I just want to thank you all for your time today, and also to thank the dozens of people and organizations who have volunteered their time and expertise to the team at Stanford to contribute to this report. Now I'm going to pass it on to Dr. Linos, who's going to talk about the learnings in more detail. Thank you.
Thank you so much, KX, and thanks everyone for being here. It's really wonderful to be able to present the results of our work and go into some more discussion. Would it be okay for me to share slides now? Okay, thank you so much. So 1 second to load this. So hoping everyone can see it now. Please let me know if not. So again, briefly, my name is Eleni Linos. I'm a professor here at Stanford and had the honor of working with a very broad team in producing this report on generative AI for health in low and middle income countries. I work at the Center for Digital Health, and our mission is really to advance global health for all through technology and digital innovation. And so this is one of the key parts of our work for the last year that we've really focused a lot of energy on, and we really hope to continue. So please stay in touch. We would love to continue working with you on future projects in this space. I'd like to highlight and thank the research team that really involved people from across the globe and across institutions, the Bay Area Global Health Alliance, of course, and Advancing Health Online that KX mentioned, really conceptualized and initiated this work through their generous funding, as well as the Center for Advanced Study in Behavioral Sciences at Stanford, led by Sarah Sewell and Zach Ugolnik, and many of the collaborators who worked on this report. So briefly, just to give you a little bit of the methodology of how we got to this report. This research was conducted in both quantitative and qualitative methods. This included two expert workshops, one held in Stanford in October and one in Nairobi in December 2024. We also conducted in-depth qualitative interviews um, with academics, health system leaders, implementers, and funders, many of whom are with us today. And we also ran a survey that had about 145 respondents, and I'm going to show you some of those results today as well. So altogether, this mixed methods analysis encompassed about 280 projects funded by 10 different organizations. Some of the interesting graphics in the report, and I can't see the chat, but I'm hoping someone can pop the link to the report in the chat so people can access it. Um, included the most commonly funded health areas. We also looked at what type of diseases and projects were funded, and really, as you can see in this, about 30% of the the projects were health system strengthening, and also a big component in green is sexual and reproductive health, as well as maternal and newborn health. When looking at classifying the interventions by who they are aiming to influence or support, we found approximately a third of these were direct to consumer. For example, health related behavior change or health education and awareness initiatives. About a third were direct to providers. So, trying to help providers with diagnostic and triage tools or clinical decision support, and about a third were system level, uh, uh, for example, workflow optimization, health system efficiency, or public health surveillance projects. In our survey results, we found that the majority of funded projects were based in Africa. This may be a factor of the distribution in the Nairobi second meeting that we held, but this was the geographic distributions of the projects included. And some of the questions that the survey respondents answered were quite interesting, and I'll show you a few of these results. So, in response to the question, what are the primary use cases you would like GenAI to be used for in this setting? About 50% wanted health education and awareness, followed closely by clinical decision support and health related behavior change. When asked about which areas our stakeholders felt should be prioritized, communicable diseases was the most common answer, followed by maternal, newborn, and child health. And when asked what stakeholders felt were the most important factors for success, workforce capacity and training really was extremely common, with over 65% or 61% response choosing that one, followed closely by technical infrastructure. And perhaps the most interesting slide to me is this one on barriers. What are the key barriers to using GenAI in healthcare settings in low and middle income countries? Um, and here I almost see all of these listed as potential barriers that we need to focus on addressing, starting with the fact that large language models are not trained or fluent um, in local languages, the lack of other required digital infrastructure, access to digital devices, internet, unstable internet connection. There were several concerns about incorrect outputs or errors by or inaccuracies generated by these models, as well as the context of low digital literacy or awareness. And you can read more about this. So this takes us to the key recommendations. I'll give an overview of our 5 key recommendations, and then we'll dive in deeper to each one. So our first one was sharing learnings. So stakeholders really wanted to learn more from each other's experiences. And this was especially important given how quickly these technologies are evolving. The second one was focus on actionable measurement. So again, a theme that emerged throughout this research was that we need better ways of measuring the benefits, the costs, the risks in a way that provides rigorous and timely data. The third focused on language, again, noting the differences in quality of models vary by language. And the last two are focused on improving technical capacity and shared infrastructure, as well as improving the basic health infrastructure. So these are the 5 recommendations, and in the next 40 minutes or so, we're going to dive deeper into each of those and hear from some of our partners. But I wanted to end this introduction by sharing this quote by Fei-Fei Li, who leads Stanford's Human-Centered AI Institute, and put this into context. So Fei-Fei says, to unlock the full potential of generative AI in healthcare for low and middle income countries, we must bridge technical innovation with local realities. This means sharing knowledge, building inclusive infrastructure, and creating systems that learn and evolve with communities. The true measure of success is not just technological advancement, but the lives we improve and the health disparities we reduce through thoughtful collaborative action. So again, wanted to thank Advancing Health Online, who initiated the idea for this work, which has now generated a lot more initiatives that will follow through, as well as the Bay Area Global Health Alliance for being our key dissemination partner. And with that, I'll transition to a discussion of our very first recommendation, which is focused on shared learnings. So, in the context of shared learnings, as I said initially, this theme came up that really we need to produce practical guidance on how to identify LLM applications while mitigating risks, and then pilot, validate, and scale them. So, having some regular update process, given the technical capabilities of each of these teams varies and changes over time, and establishing a regular process to identify successes and disseminate learnings, including case studies. So with that, I would love to call on Shauna Cooper from Adare to tell us a little bit about why this recommendation is relevant to you, Shauna, and what additional data or evidence do you need to be able to integrate this recommendation into your work?
Fantastic. Thank you so much, Alani. So I'm Shauna Cooper, Director of Product at Outray. My background is in public health with experience both in big tech at Microsoft and in healthcare systems in the US and abroad. Outray is a nonprofit co-headquartered in the US and South Africa. And for nearly 7 years, we've focused on accelerating health equity in resource-limited settings through co-designed, safe AI solutions. Just this week, so this is very timely, we launched Self-Care from Anywhere. So this is our first WhatsApp-based program supporting HIV prevention and care for adolescent girls and young women in South Africa. It's live. It builds on our multimodal AI platform, which includes computer vision tech that has now interpreted over 1 million rapid diagnostic tests across HIV, malaria, COVID, and many more. And in this Self-Care from Anywhere program, we're just beginning demand generation, and already nearly 200 young people have started the process, with 11% already just in the first days hitting deep engagement metrics. And it's clear to us that trusted, accessible sexual and reproductive health information just is a real need. One of the things that we found the most questions around is actually around menstrual health. There's a lot of people that are coming with questions about, like, is this normal? What I'm experiencing, I don't have anybody else to talk to about it. So the shared learnings recommendation that Alani just went through describes is really personal to us because sharing learnings starts with understanding performance. So when we started testing LLMs, we realized how hard it was to pick the right model for each task, as the models, as we all know, change so frequently. So we needed a way to ensure that the responses served to our clients were safe, relevant, and appropriate. So what we did is we built an LLM evaluation framework to assess both. So one of the first ones we look at is factual accuracy, what the AI says. Is it true? Is it accurate? Is it real? Tone and relatability is the second axis. How it says it. Does the message land with the client? So how do we do this? Well, we start by defining the task. Then we build a set of core ground truth questions and answers. And then we generate output from each model and compare. It helps us know when to update prompts, add or remove reg content, especially to bolster local context, or switch models entirely. We have also been understanding how well LLMs can build rapport, like trust, and how they can guide behavior change. And early signs are encouraging. For instance, in some of our studies this past year, girls told us that it really felt like the AI companion was listening to them. So now we believe strong insights start with strong design. All of our projects begin with in-person co-design sessions with stakeholders and users, followed by rapid iterative testing. So we also define success and metrics upfront, not retroactively. Like a consumer tech company, we track engagement through a rigorous funnel, active users, retention, escalation rates, trust. And then we combine that with the rigor needed in healthcare, using an M&E framework that continuously monitors for safety, harm scenarios, clinician performance, consumer engagement, and use outcome indicators like prevention uptake. To generate learnings, we then take a multi-pronged approach. We are involved in rigorous field studies, which lead to publications, and we post key insights on social media, blogs posts, and in case studies like this so that we can get some of these learnings out there into the community faster. And while the numbers matter, what resonates most are the stories. Like the teen who asked if it was safe to share soap with her sister, who she lives with, who also lives with HIV. That's the human side of the data and why we care so deeply about getting it right. To go further, we need more transparency across the space. The technology is evolving so fast that it can be hard to tell what's been rigorously tested and what's just promising on paper. But coming from consumer tech, many of us are used to a mindset of trying, learning, iterating quickly, even failing fast when needed. We take that same experimental approach at Outeray. But in global health, it can be tricky because funding often favors proof of success that's already happened rather than learning from what didn't work. And yet, if we want real progress, we really need space to share both. At Outeray, we're committed to sharing what we learn, especially as we expand our work in South Africa and Zimbabwe this year across HIV, TB, mental health, and sexual health for key populations, men and youth. This field is moving fast, as we've said. Let's make sure our learnings move just as fast, shared with purpose, like calls like this, measured with care, and always grounded in the lives we aim to serve. Back to you, Alani.
Thank you. Thank you, Shauna. That was very helpful. We'll move to our second recommendation, saving Q&A for the end, which focused on actionable measurement. So what we mean by this was that stakeholders wanted better ways of measuring the benefits, the risks, in ways that provide rigorous data, rigorous scientific evidence of effectiveness, but also in a timely manner. For example, funders cannot wait several years for results of a randomized controlled trial to guide their annual investment decisions, but we still need scientifically valid ways to establish success and measure what's working and what's not. So the recommendation focused on establishing standards for measurement and best practice with specific examples, and identify opportunities for implementers to partner with academics on measurement. Since many of these projects are in pilot phases, we really felt there was a time-sensitive opportunity to accelerate these partnerships. So to give feedback on this recommendation on actionable measurement, I'd like to call on David McAfee from Viamo to tell us a little bit more. What about this recommendation is most relevant to you, and what additional evidence do you need to be able to integrate this into your work?
Great. Thank you, Eleni. And hello, everyone. Let me just take this opportunity to thank the Bay Area Global Health Alliance and Stanford for featuring Viamo in the white paper and for organizing today's launch event. Much appreciated. So just 2 minutes on Viamo. We're a platform company, and we've created a voice-based search engine that's accessible on basic mobile phones like my old Nokia here. Because the problem we're trying to address is that there are billions of people in the world who are isolated. They're not yet online, and as such, they're cut off from the information and opportunities they need to lead healthy, productive lives. Now, this includes members of the general population, consumers, and also frontline health workers, agricultural extension agents, primary school teachers, etc. So isolation is the problem, but the opportunity is that these vulnerable populations do have access to simple, basic mobile phones. In fact, in many countries where we work, it's more likely that a household owns a mobile phone than a television or even a radio. So that gave us an opportunity to engage with hard-to-reach groups by repurposing old technology. So interactive voice response, or IVR. So you use IVR when you call an airline, right? Push 1 for ticketing, push 2 for reservations. When our active users call us toll free, they hear, welcome to the service, press 1 for public health, press 2 for agriculture, press 3 for education, press 4 for news and weather, etc. So we call our direct-to-consumer search engine the Viamo platform, and last year we had 27 million active users across 19 countries in Africa and Asia. They conducted over 650 million knowledge searches, and they spent about 1.6 billion minutes on our platform. So thanks to our innovative telecom partnerships last year, we secured about $200 million in free airtime for inbound calls to the Viamo platform. So the way we'd like for you to think about us is that we're essentially a cross-sectoral delivery channel, and we have over 700 partners who are sector-specific experts like UNICEF and many of you on this call today who partner with us to put their content on our platform. Okay, so what are we working on now? When OpenAI launched ChatGPT, it gave us, as a voice-first company, the opportunity to experiment with generative AI. And in 2023, we added an Ask Viamo Anything feature, or AVA for short, that's powered by generative AI to our Viamo platforms in Zambia and Nigeria and elsewhere, and the results have been promising. So our users quickly learned how to ask AVA questions, and their interactions on the platform became more conversational as they asked follow-up questions. And AVA turned out to be really popular. So to date, we've received and answered over 700,000 questions across a really wide range of subjects. So public health and entrepreneurship, agriculture, education, among the most popular. And we see initial promise in AVA's impact, given the serious and thoughtful questions asked by our users. So I want to learn more about contraceptives for family planning, or which soil is good for planting beans and cabbage, and then even what business can a 12-year-old start in Zambia in the winter. List 30 of them. So in terms of the white paper's recommendations, focus on actionable measurement. This really resonated with me and with Viamo. So we work a lot with the Gates Foundation. In fact, last month, we were invited to present our work to Bill Gates and his senior leadership in person. And I have to say that they're all about the importance of measurement. So as a platform company, they appreciate our user statistics, because radio and television stations, they really struggle to accurately report on how many listened to a particular public service announcement. Gates is also really interested in the Ask Viamo Anything data set of questions asked and answered, because we might be the only organization in the world who has collected questions asked by an offline audience of a generative AI-powered search engine. But what the Gates Foundation really cares about is positive, measurable outcomes. How many women went to a clinic and received a family planning consultation because of their interaction on the Viamo platform. So this traceability back to our platform is the holy grail that we're shooting for, because from there, we can then begin to calculate the average cost per family planning client seen and seek funding to scale. So maybe let me stop there. Elena, let me turn things back over to you.
Thank you so much, David. That's so interesting, and I love the example of what businesses a 12-year-old can start. I might get my own 12-year-old to try it, but I wanted to, in the interest of time, I know there'll be a lot of questions. I wanted to make sure that we keep going and talk about the third recommendation of the report, which focused on improving language and localization. So experts noted that the quality of models really varied by language, by medium, with voice, particularly important in low literacy settings, as we just heard, and by use case. So health-specific contexts and health conversations may have different, uh, really different levels of accuracy compared to non-health topics. And the fact that large language models are not trained or fluent in local languages was the most commonly selected barrier for using GenAI in healthcare settings in these countries in our quantitative survey that I showed you the results today. So we really wanted to highlight the importance of identifying this gap in language quality and establish standard measures to evaluate model performance across different languages, but also across specific health contexts to ensure consistent quality for people regardless of where they live or what language they speak. And also highlighted the importance of curating high quality data sets for underrepresented languages, including region specific dialects, culturally relevant health information, and voice data for low literacy populations. So with that, I might tell you another story. Earlier this morning, I presented to the government of Paraguay, who's working on their national development plan with UNDP, focusing on digital health. And I hadn't, even though we use Zoom all the time, I hadn't seen the live translation feature before that allowed people to listen to the conference in whichever language they selected. And it really resonated with this key finding of this report because, you know, it was so wonderful to be able to get really high level, very, very complex scientific information in English, even if someone was presenting in Spanish. So to talk about language, the importance of language, I'd like to call another partner of ours, from Girl Effect, Karina Rios-Michael, to tell us your thoughts about this recommendation, why it's relevant to you, and how you plan to leverage or integrate it into your work. Welcome, Karina.
Thank you so much. Yeah, so a little bit about Girl Effect. We leverage the power of media to unlock the power of girls. And we do this in really cool and fun ways that young people love. So we have TV dramas, radio shows, magazines, clubs, and AI-driven chatbots across Kenya, South Africa, and India. And for over 10 years, we've been answering young people's and girls' questions about growing up. I think we've received around 35 million messages to date, and we currently have 100,000 monthly active users across our chatbots, with over 1.5 million users across all of these countries. Why localized languages are so important to us? Because throughout the 10 years of building social behavior change communications and addressing norms that have gender normative components to it, personalization around this messaging is critically important. When you're working with young people, they need to relate to the content, they need to identify with the types of things that we're trying to support them with. And for many girls, talking to a doctor or talking to a healthcare worker is something they may not feel ready to do. And they often don't have spaces or judgment-free spaces to do that in. So what started off as a column in a magazine, Ask Auntie, became a text and radio show, has turned into our Big Sis chatbot in South Africa, which has a million users now, and Wazi in Kenya and Bulbehan in India. And we've been working with AI for over 8 years now. And so when ChatGPT came along, we had really live problems around localizing languages. Our original BERT-based models weren't able to replicate our success in South Africa English, in India or Kenya, which are really unique languages that young people speak, which is often mixed-coded Swahili and English and slang, or Hindi and English. So these latest advancements in language models allowed us to do two really big things. One, scale the number of questions, so answers to these questions, and personalize them. But I want to hand over to Alex and Soma, who are true champions building practically the last year how we're able to do that. Alex, over to you.
Yeah, I think it's really interesting to look at all of the variety of use cases related to languages that we can work with. And I think they fall into two categories. Languages that the LLMs are somewhat able to process, and languages where there's a very, very low level of trust that we can process the question or the comment asked by the user and do something meaningful with it. Key to our approach is the use of evaluation, and I'll pass over to Soma to discuss how we are working with evaluation frameworks across multiple languages. Over to you, Soma.
Thanks so much, Alex. And we, as Alex mentioned, we're putting a huge emphasis on evaluation, as Audrey mentioned as well. It's a key component to making sure that our answers remain accurate, safe, reliable, contextually relevant. And we've already done a significant amount of work developing our evaluation framework in English. But one of the, to generate this question around the additional data and evidence that we need to really leverage this learning, like this learning on language, our newest efforts are focused on making sure this evaluation framework can actually be extended to other languages. So right now, Karina mentioned the mixed coded languages. One of them is Shang, that is used in Kenya. And we're currently in a process of trying to understand how effective our evaluation framework is in Shang and how much of it we actually have to extend or adjust our data sets or potentially even adjust our metrics to handle Shang. I can already tell you, we've already done a lot of anecdotal work in these languages in both English and Shang. I can tell you in English, GPT loves to talk as a man and not as a woman. And in Shang, GPT is not very good at understanding or generating youthful language. It's a very formal kind of instructor-like tone, which doesn't resonate as much with our audiences. And so this is clearly like an area that we have to do a lot more work in. And that's where we see a lot of our future work around evaluation to ensure that we actually can potentially, either using prompt engineering or even further fine-tuning, actually get these models to a place where we can trust them to talk to our audience the way that we want to talk to them, which without kind of alienating them. And so that's a really big part of the additional evidence that we're hoping to generate, because we now have anecdotal evidence that it's not that these models are not very strong at generating mixed coded language, but we'd like to extend it, make it quite robust, so that and to do that, we have to actually extend our evaluation frameworks to address these languages. So I'll hand back to Alex really quickly.
Yeah, thank you, Soma. So to address the other use case we have, of languages we don't feel are supported, we really need to find ways as a community of practice to be able to address this key issue and bring the amazing potential of GenAI to people in countries where there just aren't the data sets available to be able to create this type of great engagement. A fantastic example actually in Nigeria would be with Hausa, where the practicalities of how the language is spoken affects the technology. In order to be able to do this, we really need to be able to collect data as a group, to be able to work out how best to process that data, and obviously, and most importantly, to include the groups who will benefit from these technology advances. I don't necessarily think that one single organization is able to do that within the community. I really think this is in the words of the Gates Foundation, a grand challenge that we need to try to solve together, because to get it to a point where it's trustworthy and performant and of a high enough quality that really brings the most out of it, there is a lot of work that has to be done in this area. We really want to be able to get to a point where all of our users are able to engage with this. I'd like to be able to, really bring together everybody here to try to help solve that problem. Karina, do you want to, any last statements from us?
No, I think we're happy to hand it back over. Thank you.
Thank you so much. Next, I'd like to move on to our fourth recommendation from this report, which focused on improving the technical capacity and shared infrastructure. So what this refers to is the fact that expert noted that the technical capabilities of these GenAI implementers vary dramatically. Similarly, some funders and health system leaders also felt they may have gaps in their own knowledge that, if addressed, would allow them to make more impactful funding and procurement decisions. They also noted that some technical barriers likely would be addressed more centrally rather than in a fragmented way. So our recommendations focus on identifying elements of technical infrastructure that should be shared and establish a way to centralize these efforts, as well as provide technical capacity and consulting expertise to health system leaders, funders, and implementers. And to discuss this recommendation, I'd like to call on Jay Patel, the Director of Technology at Jacaranda Health, to tell us a little bit about what this recommendation means to you and if you have any additional advice on leveraging and integrating this into your work and others broadly. Welcome, Jay.
Thanks, Eleni. So the 2-minute overview of what Jacaranda does. We're trying to solve a problem where 1/3 of maternal deaths in Kenya happen due to delays in seeking care. And we're trying to do that by offering a free health information service over SMS to date about 3 million moms across Kenya and Ghana and soon Nigeria have been enrolled into the service. They get tips about their health, the health of their baby, and importantly, they can ask any questions they have. So our audience is largely on the lower income side of the spectrum. They have feature phones like David showed earlier. And they can't just do something that we all take for granted, which is get online or open up a browser and Google any questions they have. They don't often have a data connection. So we offer the opportunity, or we offer the option to text in any questions they have over SMS for free that they can ask during and after pregnancy. And we get about between 10 and 12,000 questions every single day here in Kenya, mostly in informal Swahili. Moms are using abbreviations and local vernacular, local slang. And so when GenAI came along, we realized there was an opportunity, and we developed a Swahili-speaking large language model, which is based on Llama 3, to help respond to the questions. It responds now to about 70% of the questions we get, but that allows our help desk team to focus human intelligence on where it matters most, which is the urgent questions like bleeding or severe headaches or sudden swelling. And we can flag these, make sure that the mom is directed to a facility as quickly as possible so that they can get the care they need. The language model worked in Swahili. We've open sourced it and also extended it now to Hausa and Yoruba for Nigeria, Xhosa and Zulu also for South Africa, and that's available for anyone to use. But the report made a good and somewhat obvious point, which is to match the tool to the context. Right? Don't default to AI when things like foundational infrastructure, power issues, or connectivity issues are lacking. Solve the problems you're facing now. Worry about AI when it becomes relevant. But again, that doesn't mean that AI can't be utilized in these situations. We all have, most of us have, what I call the lowest common denominator technologies, like SMS, like access to a phone line. So people can call into services like Viamo. People can text into services like ours and just be able to get the benefits of these AI systems through these very basic technologies. The second point is that data is the fuel that powers AI. But if your data is locked behind or inside filing cabinets, all your workflows are paper-based, then you're not even at the starting line. So investing in digitizing patient records, electronic medical record systems, that will provide the necessary foundation for more sophisticated innovations, which then lead to the opportunity to implement AI. Lastly, developing shared and openly accessible local language data, language models, maybe on a country by country basis even, which will ensure that AI solutions are not only accurate, but culturally relevant. And then these centralized language resources can allow universities and implementers to focus on fine-tuning them for domain-specific applications as opposed to trying to build a language model from scratch. And the point was made earlier, organizations like ours and others should and can share the work we've done to help just the ecosystem grow. Yeah, so those are my thoughts. Back to you, Eleni.
Thank you, Jay. That was really helpful. So our final recommendation, which relates to the infrastructure and the basic health infrastructure of where these models are being used, was a theme that came out throughout the research, which was that relates to the risk of inadvertently perpetuating the digital divide as a key concern. So no matter how advanced AI models and data sets become, their potential to affect behavior change is wasted if the people who need them the most cannot access the necessary digital or physical infrastructure. For example, due to lack of a stable internet connection or lack of access to healthcare facilities that may be recommended by the Gen AI chatbots. So our recommendations were prioritizing investment in basic healthcare infrastructure alongside with digital interventions, as well as considering whether GenAI is the highest impact way of addressing the particular use case, taking into account existing basic healthcare and digital infrastructure. So taking a step back and thinking about whether or not, given the specifics of a situation, that is the right decision or the right choice of tool to use, as well as evaluating every organization's digital readiness before deploying AI tools to avoid costly failures and focus the funds on ensuring the digital readiness is there before the models are launched. So to discuss this final recommendation on basic digital and basic health infrastructure, I'd like to ask Aman Kular from Nora Health to comment.
Yeah. Hi. Uh, Thank you for having me, and thank you for including our work in the white paper. Hi everyone, I'm Aman, and I'm a research partner at Noura Health and a PhD student at Georgia Tech, investigating how AI can support global health infrastructures. So at Noura Health, our mission is to empower family caregivers to deliver life-saving care at home. We accomplish this through the Care Companion program, which starts with in-facility training and continues with a mobile-based support system that sends tailored reminders and educational content. This service is called Remote Engagement Service. This technology-enabled approach ensures caregivers have the guidance they need at home, while our dedicated help desk, staffed by licensed nurses whom we call the medical support executives, or the MSEs, stands by to answer questions and offer timely advice, making home care both accessible and effective. We have approximately 1 million care recipients subscribed to RES, and we receive around 10,000 messages each day. Our first AI intervention, which we started in January 2024, was to support the nurses reduce their workload through an intent classification system, which is part of the case study included in the white paper. So for the discussion today, I'll be discussing the importance of improving digital and basic health infrastructure in our intervention, drawing from the fifth finding outlined in the paper. And I found all the 3 recommendations, which you just pointed out, particularly relevant to our work. And I would like to share how we are incorporating these insights. First, the authors have emphasized the need to prioritize investments in basic healthcare infrastructure alongside digital interventions. To incorporate this, we are looking to predict high-risk pregnancy cases through AI and collaborate with on-ground community health workers to ensure that these cases are addressed effectively. Second, the authors caution against assuming generative AI is always the highest impact pathway. In response, we have adopted a critical approach to its implementation. Rather than a one-size-fits-all adoption, we're employing a co-design methodology that is user-centered and contextual. This ensures our solution aligns with the public health resources available during the deployment. Specifically, we have included verification workers in our workflow to highlight the inaccuracies of AI, and through semi-structured interviews of the MSCs, we have identified the factors that should be considered when considering the use of GenAI in our work. Our findings recently got accepted at CHI 2025, a premier human-computer interaction conference, in which we found that the productivity of our MSCs increased through GenAI in the 6 Indian languages. But we also assessed the well-being of the verification workers and highlighted their aspirations through the use of GenAI by leveraging Amartya Sen's capability approach in global development. Third, the authors also stressed the importance of evaluating digital readiness prior to deploying AI tools. This insight has shaped how we identify stakeholders for designing our first set of GenAI interventions. By focusing on the contexts where minimal upskilling is required, we can ensure smoother adoption and greater immediate impact. We are combining this with a rigorous mixed methods evaluation, comprising of ethnographic inquiry, semi-structured interviews, and analysis of usage logs to understand the efficacy of our intervention. We leveraged design-based implementation research methodology and understood how human-centered evaluations should be conducted of generative AI systems. Finally, with respect to leveraging the findings in our work, I believe that the lessons from other case studies were quite helpful, but some details with respect to how certain evaluations were conducted may be quite helpful while incorporating these learnings in our use case. For example, the Viamo's intervention, which we found extremely interesting, but understanding what the sample size of their audits were or the themes of their evaluation questions would be quite helpful for tailoring our own evaluation. Additionally, when prioritizing investments in basic health infrastructure, some guidance on strategies to navigate systemic barriers would be quite helpful. For example, how should we design our intervention when we support a beneficiary with a community health worker in a high-risk pregnancy intervention, but the nearby health facility refuses treatment or asks for additional money? Some examples and details of how projects leverage GenAI to fill the gaps in the public health infrastructure would be quite helpful for our work in the future. Yeah, thank you.
Thank you, Aman. That's very helpful. And thank you to all 5 of our case study partners for being featured in the report, for all of the work you put into sharing data and information, and also for presenting and sharing your insights today. So with that, I would like to transition to KX Jin, who will lead us through moderating the Q&A session. KX, over to you.
Great. Thanks, Eleni. And thank you all again. I think one thing that was tremendously helpful for me, both as part of this project, but also just even hearing it live today, was getting the details on the specific applications of GenAI from many of the organizations that spoke today. I just find it really helpful in making the conversation much more concrete and, separating out some of the substance from the hype, but also identifying, where are the gaps and challenges going forward. I think we mentioned the report earlier, but if you're interested in learning more about some of the things discussed today, there's case studies for all of the things discussed today as part of the report. So in this last section for the live session today, we're going to open things up for discussion. We'd really love to hear from you all. What questions do you have based on what's been discussed today? And do you have any comments to add about any of the recommendations discussed, including from your own experiences? So, please enter your questions into the chat or raise your virtual hand, and I'll do my best to moderate. We've already gotten a few, so I'm going to start with, I think, Pippa from Turn, and then we'll move through a few more.
Hi, KX. Thanks so much. Hi, everyone. I'm Pippa Yates, one of the co-founders at Turn. My background is in design and behavioral science, and at Turn we have a chat platform that supports over 200 organizations to deliver vital services using chat and LLMs. So my question today is actually very, very practical to all of the teams here is there's fantastic data and guidelines in the report around frameworks to follow, how to do human-centered design for this use case. But I'd love to get down to, what are you all writing in that prompt box for your LLMs, and where should people start? There are obviously different types of tasks that are listed in the report around summarization or classification or extraction. And so please be specific, but I'd love to hear from you, what have you learned about writing a great GenAI prompt for health behavior change?
That's a great question. Do any of the people who are implementing these projects want to share an answer to that?
Hi, happy to answer from the Viamo side. So one of the projects we're working on is clinical decision support for health workers in Nigeria. And we do a lot of the basic prompts, such as, you are the health worker's boss. The health worker is in a low resource setting. The health worker may not have access to the internet, may have limited education, et cetera, et cetera. But I think the most important part of that prompt is encouraging our AVA system, or the generative AI system, to ask questions back to the user until they're comfortable to give clinical decision support. So oftentimes our system will ask the the community health extension worker, several questions before they'll provide clinical decision recommendations.
Thank you. I guess maybe if other people are raising hands to answer this question, I'll go there. So I think Shauna, is that relevant for this question? Great, thanks.
Yeah, absolutely. So I think that one of the things that we found is that pretty small changes to the prompt can shift how the LLM responds. So one of the big things is, like, you need to test. You need to be, in tech, it's called dog fooding. You need to be dog fooding your own product. We actually have internal bug bashes that we do multiple times a week with the whole group. And I think that that's been a way that we've been able to understand when we need to make tweaks, and also how the small tweaks that we do adjust. So I think that that's obviously a big piece of it. And then making sure it's part of the language of how you create the prompt. So for instance, how do you want the LLM to respond? Do you want it to personify itself, or do you want it to not? So you have to tell it those things, and all of those little pieces and parts. So needless to say, there's a lot of testing and a lot of trial that goes into it. And it's not something where the first prompt that you create is the one that you're going to end up with.
Great. And I guess maybe last response on this one before we move to another question. Is someone from Girlfriend Soma? Is that also for a response?
Yes, thank you so much, KX. So basically at Girl Effect, as we talked about, tone and language for us is super important. So we've been doing a lot of work with prompt iteration. And one of the first things we quickly picked up is that each LLM needs its own prompt iteration process, for sure, because each LLM has, it seems, at least from what we can ascertain, because they're not always very clear about the fine-tuning process that have gone into these LLMs. Each LLM has been, to different degrees, tuned to actually listen to different prompts. So we very quickly realized that a prompt that worked really well for GPT was completely ineffective for Llama, and didn't listen to half the instructions. So what we've actually found is that we find that we've been actually building prompts by talking to GPT almost, or talking to the LM that we're trying to build the prompt for. And a lot of it for us has been a negotiation between what is most important to our approach and what parts of that can be condensed and distilled into a prompt, and then how long can the prompt be before it's too long for the LLM to really understand. But that's kind of where we are right now. But we're actually hoping to eventually use frameworks like DSPY. That's also why our evaluation framework is really important, because we're actually hoping to eventually iterate on prompts programmatically and use our evaluation framework to actually determine whether the prompts are good or not. But yeah, it's quite a process. But it's a very interesting and fun process.
Great. Thanks for the great question and responses. Going to move on to the next question, which is, I think, coming from Gwydion at Path. So if you're on, please chime in.
Thanks, KX, and it's great to be here. I'm Gwydion. I'm Deputy Director of AI at Path, which is a global health NGO. So I'm relatively new to Path. I joined around a month ago, and since joining, have been really pleased and excited to see how we collaborate with local partners in all of our AI work. So, for example, we're developing and evaluating some LLM-enabled clinical decision support systems in sub-Saharan Africa. I see a few of our partners for that work on the call, but we've also had the joy of working with a range of local innovators in Kenya, Rwanda, and Nigeria throughout that project. They all bring technical know-how, but also really deep understanding of local context, local needs, local languages, and without them, I struggle to see how we would have the same level of impact. And I think the importance of local partnership speaks to a lot of what's in the white paper. And staying on partnerships, but taking a slightly different angle for a question back to the researchers behind the white paper and also the various people that have spoken about their work. What role do you see in all of this for model providers? So for the Googles, the OpenAIs, the Metas of the world, should their involvement simply be that they generate models which are then taken forward by local and global innovators, or is some form of deeper partnership more appropriate? And I guess what's behind the question for me is that some of the barriers that came through the white paper, things like network coverage, dealing with model inaccuracies, could be solved by foundational AI research, and that research is maybe most easily done with model providers.
That's a great question. Does anyone want to take that? If not, I'm also happy to provide a little bit of my thoughts here, having worked a fair amount in various capacities. Actually, looks like we have a couple responses, right? So do you want to go first, Aman?
Yeah, thank you. Yeah, that's a great question. And I do agree that the second approach you alluded to, that is, if given a chance, the model providers could establish relationships with the community partners in some capacity, might be a good path forward to understand the contextual needs, wants of the communities we're attempting to serve. So, and there are some interesting examples of this partnership. For example, Google India collaborates with Arman. I think Arman is another great nonprofit organization working in maternal and child health. So the way they collaborate is some of the researchers from Google uh, do conduct field studies with Arman local partners. So that contextualizes the needs, and which in turn informs the efforts of model scaling. So for example, now they're working on Indian languages, and how that partnership developed was interesting. I think the second pathway of collaboration is one in which we at Noura are experiencing with OpenAI, where one of our grants is being funded by OpenAI, and we have weekly sessions with the engineers where we are able to list out our challenges we are facing during our use of the models, and the problems we are facing in implementing the models that are developed. So that weekly office hours with the engineers is quite helpful in understanding our contextual needs and the challenges that they're facing, and an iterative development process.
Great, thanks. I'm assuming the next two are also in response, so I'll just go. Maybe Alex, is this a response to the question?
Yes, it is. No, I think there do seem to be opportunities like in the funding sector at the moment, which are related to the providers of these LLMs wanting to work in areas where we work in as a sector, and that's very positive to see. Whether that's related to multilinguality, whether that's related to the big health challenges that we want to solve through the types of implementations that we do. I guess an interesting thing, is the extent of the motivation of these organizations, like given ultimately their kind of financial imperative to do it. And I see what we can do as a community of practice is to be able to scrutinize the data, to be able to use evaluation frameworks that we've created in order to create benchmarks related to those languages and demonstrate exactly where it's working and isn't working, and hopefully then encourage real improvements based on the stories that we can tell, which may otherwise be overlooked as part of this classic long tail of progress, which I feel is becoming more pronounced since the advent of GenAI. I feel like it's a big thing that we've addressed over the last 10 or 15 years within the ICT community. So it is a worry how that's starting to expand again. And I think we need to be the cheerleaders, for making sure that this comes to the attention of the organizations who are building these models, who have the resources to make the kind of improvements that are needed.
Thanks. Yeah, that resonates a lot with me, especially the benchmarking point, because I think if we were able, and then to be clear, some of this work already is in progress, but just clearer benchmarks on language performance or specific use cases that are important, I think are a good starting place for identifying where the gaps are. And in some cases, I think just having those benchmarks themselves might spur some of these organizations to action. In other cases, it maybe requires a little bit more work, but having the measurement, I think, can be, one thing that's very helpful. Stephen, more thoughts on this?
Yeah. In terms of kind of health and localization and referring to local clinics, I think that can be achieved pretty well through RAG. We've had pretty good luck with that so far, but kind of our biggest request to big tech, and I think most of the big tech people in this audience have heard this request from me already, is languages. We need that kind of like beyond work in health, which is important, is kind of just really fundamentally, of our 68 languages, we can only do 7 of them with generative AI because we don't have really the weak links are speech to text and text to speech technologies. So that's the investment that we're hoping big tech will make urgently.
Great. I'm going to do 2 more responses on this question, and then we'll move on to a next question. Charles.
Yes, I think mine is a question, so I don't know if I can go ahead.
Oh, okay, cool. I will hold that and get back to you in the question queue. Andrew, is this a new question or response?
This is a new question. Can you hear me?
Okay, cool. So let's hold that. I'm actually going to tee up the question you had in chat next. So thank you for the question and the answer on that subject. Next question, I think this actually came from Andrew, and I'm just going to read out the question. Is like, hey, he's saying it'd be helpful to hear more about the different projects' measurement of outcomes. So beyond counts of people who use these tools, how do we know about the numbers who subsequently attend appointments or self-test for HIV, adhere to medications or the like? And what would it take to assemble the level of safety, efficacy, and cost effectiveness data that would help convince policymakers to allocate resources to a lot of these initiatives and scale them? Andrew, is there any more you wanted to add to that? And
thanks so much. Yeah, the only thing I would add is, and what role do folks on the call see for funders like NIH or others that are invested in science and moving science forward?
Great, thank you. I think it's a really rich question. Shauna, did you have thoughts here? I'll start there.
I do. I'll start with the beginning points that you meant. So one of the ways that we've started thinking about this is we start with an engagement funnel. So like it starts from the very moment that someone is scanning that QR code, if it's a QR code or however they're ingesting information, and then you're taking it through. I'm actually looking at one of our dashboards right now. You're taking it through like what are the actions that they have done so that so that you can understand where in the user journey they're dropping off, where you maybe need to make changes and updates. So like you treat this, like you bring all of the technology knowledge to bear into healthcare. And then you merge these two, and then that's where that rigor comes from. And then you being able to understand where they did engage and where they dropped off, et cetera. For understanding services received, like there's been some messages in the chat as well on this. This is hard. Like, you know, we're working in South Africa. It's thousands of clinics in South Africa. Like, how do you know whether or not somebody actually went and got PrEP? How do you know that they went and picked up their ARVs? How do you know that they actually obtained services? And while there are some cases, like for instance, in our Self-Care from Anywhere program, we do have the ability, like we have some a tighter connection there. And so we can know if there's a girl that goes to a Shout It Now bus and receives a service and eventually gets on PrEP, like we can know that because we have that connection and linkage. However, we don't necessarily know if they went to a clinic and got, you know, maybe some guidance on how to deal with excessive bleeding that was happening during intercourse or menstrual pains, etc. So what we do there is we focus on self-report, because at the end of the day, that's the piece of information that you know you can get, is you can ask the client if they were serviced. It's not going to be 100%. I understand that in the medical community, it's not considered validated information, but more often than not, it's going to be accurate, and it's going to point you in the right direction. And then, sorry, one other point for self-tests. In our case, we actually are guiding, like using in the chatbot and LLM, we're guiding the client through a self-test right within WhatsApp. And so we're telling them the steps, and then we have them take a picture of that rapid diagnostic test. And so we know that that happened. And that's actually one of the things we're able to pull back into, we call it our clinical portal, but we're able to pull it back into the clinical portal that a nurse can look at, so that they can then actually go out and, under IRB in this case, but they can actually give PrEP based upon the photo of that test that happened. So that person doesn't even have to go in a clinic and spend the extra like 20 minutes waiting for a test to be run there to get access to PrEP, as one use case.
Thank you. I think Karina and David are probably raising to answer this question. So I'll take those two, and then we'll move to the next question, which I think will hopefully come from Charles. So Karina, go ahead, please.
Yeah, I also put in our chat just because there's quite a lot of data we've been collecting over the years and evaluating over the years in terms of the role that our chat companions play in contributing to behavior change. So we know from third-party evaluations that we're able to increase knowledge by 20% around contraceptive options. We know that we have to integrate and work with healthcare providers. We do a lot of self-reporting, but we also work with local clinics and understand their own data. And we do share data on anonymized data to understand from them if they are actually receiving referrals from our chatbots. As a result, we can see that users that engage with our chatbots, because we have human-in-the-loop functionality, we work with Mary Stopes operators in South Africa, in Kenya, and Panda Health Hospital in Kenya, and they provide us with healthcare agents that act as chat operators on a Turn platform, and they speak to our users and book them into services at their hospitals. So we can see the full data life cycle from the point of awareness all the way to engagement, to speaking to a health operator, getting triaging, booking a service, and then going on to attend those services. So we can see that entire pipeline. 1 in 3 will speak to a healthcare agent, 10% will go on to book that service. However, we do offer a lot of choice, and not all healthcare providers have data systems in place that they can share with us. So there's also an underreporting at the time of access as well. So as Audrey was suggesting, self-reporting is also very key for us. So we can try and capture, at least at an intentionality phase, young people are accessing or uptaking new behaviors as a result of engaging with these conversational interfaces. We've also been running a lot of GenAI pilots in which we're comparing legacy models versus GenAI enhanced systems. Early findings are really exciting. We're seeing 200% increase in engagement to those exposed to GenAI enhanced system, and 11% increase on top of our benchmarks towards intentionality to access services. But I'll stop there. Sorry, that's a lot.
Oh, that's super helpful. And this is like a very rich question that we'll love to follow up more on separately. It's also something I've spent a very long time about, both in the commercial sector as well as now more in the public sector. Maybe last two responses. David, is this on this topic? And then Nicole, also on this topic? Okay, Nicole's new question. Okay, so David, last one on this topic, and then I'll try to get some new questions in. Thank you.
Okay, great. I find myself agreeing with Shauna and Karina a lot in this call. Just very quickly, the challenge here, of course, is that we're trying to measure what amounts to an off-platform action, right? So somebody has to put their phone down and then go to the health clinic and book an appointment and have that family planning consultation. And then we have to figure that out. And it's a really big challenge, to be honest, because a lot of our partners don't have a digital platform that we can handshake to in ways that are convincing. We still have to figure this out, because this is the direction that the world is going in. The world wants to be able to measure the efficacy of these programs and platforms. It drives me a little bit crazy because I've been in this business for a long time. And in the old days, we never thought that one single project or one single intervention could make that big of a difference at scale in people's lives. It needed to be a collaborative effort across many organizations, coordinated by the government with comprehensive communication campaigns. But I have to get off my soapbox and just understand that this is the reality that we live in. And we have to negotiate with our partners to decide at what level do they expect in terms of rigor when we start to monitor and evaluate the projects that they fund. Is it at the level of a randomized control trial, or is it the level of self-reported behavior change? We have to figure that out.
Great. Thank you. I'll move on to another question now, and thanks for the patience. Charles, you've had your hand up, so please ask your question.
Yeah, thanks a lot, and great presentation from all the various organizations and interesting case study. My question, it's just maybe probably a lot of elaboration considering like the last but two key recommendation: one, confronting the societal biases and problems, and then also the last one in terms of local stakeholders. I would like to know from any of the presenters how, one, they engage the users in design phase, in the early phase of design, and then their various inputs if they can share, and then also two, their experiences, particularly the healthcare workers, and then in this case, the clients or the patient who are using this platform. These are my two questions. Thank you.
Thank you. Does any one of the people... Oh, Shauna, do you want to take that? Thank you.
I'm happy to. Yeah, so our biggest thing is we do co-design sessions at the very beginning. And we found that the most effective way to do it is that you designate like half a week or a week and you go and do it in person, so that you're having the opportunity to really get to know the people, and then you have them try it out. You move quickly into usability testing, and then you like rigorously go through and run those usability tests so that you're getting that feedback from the clientele that's actually going to be using it at the end of the day. And then wherever possible, like if we're building sort of other systems like clinical portals and that sort of a thing, then we had a core team of individuals who would be using that system who were part of the design team. Like they were just part of the process that went all along the way. So I think that my biggest summary is like inclusion and just making sure that you're building things with the people that are going to be using them.
Thank you. And Alex, did you have something to add to that?
Completely agree in terms of including the users in the design process. So at Girl Effect, we have youth advisory panels, which are a key part of how we operate in our countries, and we always take every opportunity we can to consult them, and that's part of our formative design process. But then on top of that, we also are very interested in doing user testing. Once our product was developed, it was very key to us that was a step that we would take and would need to pass it to understand the real life engagement which we could observe around around how people perceive and interact with the generative AI, compared to the previous incarnation of our chatbot that was very much on the Rails based. And then once we actually got to our beta testing, we made sure that having feedback mechanisms built within the chatbot would also help us to understand what the experience was like. So we made sure that I think it was an hour after the user asked their question and received their answer, we asked the user to fill in a feedback survey about their response to it. And within our A/B test environment, we did this for both the control and exposed group, which meant that we could directly see the comparative kind of like uptake and feeling towards the quality of answers that were provided in the different models. And this feedback loop, it gave us a lot of really, really interesting data that we could start to use to improve the model, see where pain points were, and create some baseline benchmarks for future A/B tests that we intend to run as we are improving our product. So always looking for feedback loops. I think the great thing about working within chatbots is that they are inherently designed for user-generated feedback. So making the most out of the technology that you have to create those feedback loops is a really, really amazing opportunity to get the real voice of the users into the product design.
Great, thank you, Alex. Aman, do you have any last thing to add to this question, and then I'll move on to the next one.
Yeah, thank you. I think I mostly just echo what Shauna and Alex said. Shauna with respect to including the users, and Alex with respect to getting feedback and iterating on our intervention. So similarly for our first AI intervention, what we did was adopt a design-based implementation research methodology, which has been in the education technology field for a couple of years, about more than a decade now. And what we did was we started with just semi-structured interviews with the nurses, because we didn't even know if we wanted AI in our intervention, what were the financial implications of using AI, and if our tech team had the resources to develop those interventions. So reflecting on what resources we have, then starting with the interviews, and we deployed our intervention in a phased manner. So first with interviews, we got the user needs, wants, aspirations, what we can do. Then we did a pilot deployment, which is just in the back end, got quantitative metrics of the performance of our AI system, measured it in F1 scores, accuracy. Then in phase 2, we showed the nurses what we were building with the dashboard, and got their feedback of if this makes sense to them, and we improved on the prompts, the accuracy of the model. And then in the third phase, we actually deployed the system. So phased deployment was what worked with us in the co-design process. Great, thank you. I think we have about 4 or 5 minutes left, so I'm going to try my best to get through a few more of these questions. I know, Stephen, Wanya, you've had your hand raised from the beginning on and off. Do you want to ask your question?
Yeah, thanks. I just wanted I mean, this is a great session, great paper. I haven't finished reading it all, but I think I just wanted to, I mean, I've got some really good responses to my question in chat. Thank you, Andrew and others. But I just wanted to bring this to our attention that, I mean, I think GenAI is great, AI is great and all, but I think we also need to, and I don't know how much the researchers focused on this, the current effect of the disruption in global health financing. For those of you who are working in, especially in LMICs, it's serious and it's really deep. I'm working in WHO to do an impact assessment on data systems, and what Jay from Jacaranda and others mentioned about the foundations that are required for this work to actually be meaningful, and actually for us provide these benefits to the patients and to the consumers of healthcare services, is being disrupted significantly. And I think if we don't address some of these things practically, and I really like what I really forget the professor at Stanford said about, we need to be practical. We can't wait for 5 years or for 3 years to generate solutions that actually work. I feel like this community, this is a time for us to generate solutions that actually work, particularly because we're in the middle of a crisis. So if you're working in these areas, I think you know what I'm talking about. For example, backbone systems like DHIS2 that countries rely on have been offline for months, for weeks, I'm sorry. And so, it's great that we need to keep advancing how we provide healthcare services using technology and data. But at the same time, we know what needs to work foundationally for everything that we're proposing to work well. And I'm sorry, Justin, I haven't had a lot of that conversation here, and I'm not by in any way minimizing the discussions here, but I think we also need to have a lot more of that kind of discussion. Thank you.
Yeah, no, I think it's a great point, and thank you for raising that in the discussion. Nicole, do you have a question? Thank you for your patience.
Yeah, of course. Thank you, everyone, for your great presentations and collaboration on this paper. I really enjoyed reading it. So I am a program manager at Unlock, which is a nonprofit organization here in the Bay Area. And I work specifically in community health education. So I'm curious about what is being done around the education, specifically for communities who may not be familiar with this technology, and kind of how you're bridging the gap to get these populations even on the platform to begin with. And then kind of relatedly, I'm curious about the spread in age range of users on these platforms.
KX, I might reply to that briefly if that's okay.
Yeah, that sounds great. Maybe you could reply, and then David's there, and I think we'll probably have to wrap after that. So thank you. Yeah.
Yeah, just to say, Nicole, that I really, really appreciate that question. And as we produce the report, obviously we use the scientific methodology I outlined to come up with the summaries. But then when I went back and reflected on it as someone who also works in the sphere of technology for older adults and aging, that was a question I had from our own report. And so I'm really, really happy you raised it. I think in this situation, because a lot of the use cases are focused on maternal, neonatal health, sexual and gender, sexual health and reproductive health education, some of the examples may be skewed towards younger groups just because of the healthcare topics that were more prevalent in these groups. But I do think you raised just a really important question that I think we need to keep in mind when working on any technology for health, which is this idea of who are we leaving behind and making sure we are not worsening health disparities, that we are not forgetting any group, whether it's people who are isolated due to geographic reasons in rural settings, who may have lower digital or health literacy, including based on age. And so designing things specifically with older adults in mind is something that I really value. So I see David has a comment too, but I just wanted to really thank you for that point.
Thanks, David. Do you have a quick point before we hand it back to Abby to close out?
Yes, very, very quickly. This is a really important point for me because at Viamo, we have the platform and we've been at this for about 10 years so that we have the traffic on the platform that allows us to do a lot of this experimentation. And the way that we built that traffic was to basically negotiate with the mobile network operators that they would provide two things to us free of charge as an in-kind contribution. Number one was the airtime that I mentioned, but number two was to promote the service for us on our behalf, because it's really the mobile network operators' solution that they offer to their subscribers. So we manage the service on their behalf, but they offer it to their subscribers free of charge and they promote it. And the thing that we've seen is that, especially for the opportunity to ask any question, the demographics of our users skew towards women and girls for reasons that I've tried to articulate in the chat. And then secondly, young audiences. So over 75% of our users are under the age of 24, and half of those users are under the age of 18. And these are just critical populations in my mind if we're going to try to help from a public health standpoint. So thank you.
Great. Well, thank you again all for a really rich discussion and engagement here. And I think I got to most of the questions, but unfortunately wasn't able to get to all of them. But we're hoping this is just the beginning of a conversation to keep building. So if you have specific thoughts or questions, please follow up with us afterward. And I'm going to pass this on to Abby to close us out. Thank you.
Thank you so much, KX, and thank you, Eleni, and to our case study partners at Outeray, Viamo, Girl Effect, Jacaranda Health, and Nura Health. We really appreciate all of you taking time out of your schedules today. At the Alliance, we've been diligent about creating a trusted, safe environment for candid conversations where we can come together to share both successes and failures. And we really appreciate the openness of the case study partners and the input from all of you with your questions today. Our call to action to each of you is to continue to engage with us on this topic, to read and share the report, and to leverage the findings in a way that will better enable you and your respective company, organization, or network to improve health and healthcare, especially in settings when it is needed most, at a time when it is needed most. The Alliance will be continuing its AI and global health discussion series in 2025 with more details to come soon. And to learn more about the Alliance and stay in touch, please visit our website and follow us on LinkedIn for updates on this and other work also related to innovative financing, private sector financing, and many other topics. So thank you all again, once again, and have a wonderful day and night.